it is my pleasure to introduce Dr. Ayushi Gupta, who is a renal specialty registrar at Hammersmith Hospital, Imperial College, NHS Trust. She recently completed a Renal Quality Improvement Fellowship at Oxford University Hospitals and the Royal College of Physicians, during which she led Changing Culture, Cutting Carbon, a multi-site green nephrology sustainable QI initiative across the 7-site Oxford Kidney Unit, with interventions spanning machine practices, waste, pharmaceuticals, and staff and patient engagement. She is a member of the Royal College of Physicians Sustainability Group and contributes to regional kidney network sustainability workstreams. Her clinical and academic interests sit at the intersection of sustainable kidney care, supported. Just mute that. Apologies for that. Ayushi's interests sit at the intersection of sustainable kidney care, supported home dialysis, frailty, and person-centered decision-making in advanced kidney disease. So, Ayushi, it's a pleasure to have you here. I'll hand over to you. We can see your screen, so feel free to begin when you're ready.
Great, thank you so much for the introduction. Hi everyone, I'm Ayushi. So basically I'm here to talk about our sort of multi-site green nephrology initiative that we took in Oxford. I don't think I need to sort of to this audience at least stress upon the importance or the sort of footprint of hemodialysis, which is 500 liters of water, consumes around 500 liters of water, generates 2.5 kilograms of waste. And what this initiative was to look at this footprint across 3 NHS sites, 7 dialysis sites that included 8 units, which meant we had across 100,000 dialysis sessions in a year. So our approach to this project was basically, we first started off with baseline scoping. So I'm sure a lot of people are already quite familiar with the resources that are already available. A Centre of Sustainable Healthcare, there's a benchmarking tool. There's also the Trunk HD case studies that were done in the north of England, which that were published, and they've all been they were quite extremely valuable in sort of us trying to figure out where the gaps lied in our practice. We then also wanted to see what the staff and patient awareness was about this sort of about our practices and their willingness to engage with changing culture, changing practice. And then we developed sort of 4 different work streams based on our mapping, which was people, machines, waste, and medicines. And then lastly, the way we managed to achieve so much was we started off with small, quick wins, small changes that led to a significant win, and then basically cross-pollinate across all our satellite units and then standardize what worked. So this is sort of the driver diagram I was speaking about. So our aim was to reduce unnecessary carbon, waste, and water across our kidney unit without compromising patient safety or care or quality, which is quite integral to delivering sustainable kidney care. Our most important was staff and patient engagement for culture change. So we wanted to educate our staff and patients on sustainability. We wanted to have green champions in every unit. And yeah, I'll come to this later. Then we had dialysis machine practices as well, what we could change about the way we were dialyzing people to make it more sustainable, save energy, save water, save money. Then we also looked at a waste management system to see if there was anything we could address there to make a difference. And then we had some medicines, we had some pharmaceutical initiatives as well. So the first initiative, as I said, without stakeholder buy-in, if you speak in SASQI terminology, this wouldn't have been possible. So we had dedicated teaching and awareness sessions for all sort of dialysis staff. I went around to all the satellite units, administered these sessions, and then obviously had these questionnaires that were done. And staff confidence before these sessions were 33% and afterwards rose to 96%. And we also had green champions embedded in every satellite unit, and they were linked in with all the online resources available by the Center of Sustainable Healthcare. So we were sort of able to link up and marry the two. And then this is one of my, one of the quotes was, one of the nurses said, "I hadn't realized dialysis had such a big carbon footprint, and now I feel that it's part of my role." We then moved on to patients. With patients, also we delivered similar teaching sessions, and there's a lot you can do with dialysis patients when they're stuck to a machine. So only 17% of our patients were aware of what their treatment, what the impact of their treatment was on the environment. And 77% of them were quite, when asked if they would be willing to bring in their blanket or bring their own cup, they were all very happy to engage. And that sort of reflected in sort of the quotes we got from them that said, "I never thought dialysis affected the planet. I just thought it was my treatment. It makes me feel part of something positive, not just a patient. And then I'd happily bring my own blanket if it helps the environment. And lastly, if it feels like a small change, but if everyone does it, it adds up," which is sort of the core theme of this entire project. We then sort of, again, building on case studies that are already available, the evidence already being there, so we weren't really reinventing the wheel. We audited our dialysis flow rates, and we found there was a bit variation in practice. So we standardized everyone to 500 mils, and obviously they were audited to make sure it didn't affect adequacy. Online priming, one unit, because of delivery issues, were already doing online priming and saving 1,400 pounds of saline bags, which was a cost benefit. And then once we spoke about this plastic and sort of the carbon footprint of having saline bags, that was also then added as a benefit. And what we found was the other units were a bit apprehensive because they were worried about patients getting hypertension and thus having that, and that was sort of standard practice and quite ingrained in all the units. But when they saw this other satellite unit was doing it without compromising patient safety, it sort of gave them the impetus to also adopt it quite easily. And then standby mode as well, again, something simple, and that's manufacturers have already said it's a low power cost, a low power range to make sure dialysis machines are more efficient. But just by increasing awareness and auditing, we were able to prove that more nurses were adopting this. Lastly, I think our signature project was the single heat disinfection. So again, based on the Trunk HD studies, one of the renal technologists in Leeds, he was able to switch to, rather than having a 45-minute heat disinfection cycle after every dialysis treatment, which can be 3 in a standard unit, they had reduced it to once a day heat disinfection and replacing them with 10-minute cycles in between. So we also did the same thing, and the change idea was, if other units are doing it, Leeds are doing it, Royal Free are doing it, why can't we do it? And this involved a lot of stakeholder engagement and a lot of governance issues. So we got our IPC team involved, our disinfection practitioners, our renal technologists thankfully also felt quite confident about it and was quite keen to pursue this. And then obviously dialysis matrons, and basically everyone got on a Teams call together and ironed up the details. Then we drafted a SOP, and then we decided to test it on one unit only. It did involve a different workflow, so the nurses had to be sort of educated beforehand. There was a different workflow on the machine as well. There were different buttons they'd have to press for the 10-minute rinse. But and by doing the pilot, and then I would go around auditing disinfection logs, making sure we were sticking to the SOP. We ironed out all the details, and we refined the SOP to make sure it was as clear as possible, got staff feedback as well. And then finally, we were able to sequentially roll it across all 7 units. And this was achieved by January of the beginning of this year. They've been doing it for the last 6 months, and touch wood, no issues identified. and it's going around really well. In terms of impact, so we are now doing 78,475 heat cycles of less. That means a quicker turnaround for nurses, that they can sort of spend more time with their patients, get on top of all their clinic admin and the sort of daily tasks they have as dialysis nurses. We projected that we're saving around £40,000 of per year, 10,000 of that being electricity and 30,000 being of Citrasil. We got an electricity meter off Amazon as well, and we were able to measure the electricity saved in the workshop, and it was quite clear that heat disinfection took 15p, whereas a rinse cycle only took 3p. Then again, using sort of data published by CSH and modeled using their per cycle factors, we were able to we can safely say that by adopting this new dialysis machine practice, we are saving around 29 tons of carbon dioxide emissions per year. We also did involve patients. We managed to we surveyed the patients dialyzing in the pilot unit, and we found that 91% of them were still confident that their machines were being prepared safely, and 84% of them said that there were improved waiting times as well. And then other work streams in terms of waste management, there were a few satellite units that had mugs in the unit, few satellite units that were still using plastic cups. And again, when I attended these dialysis assistants meetings where all the matrons and all the unit managers were there together, just by raising the idea, they were able to talk to each other and give them ideas that, you know, I got funding through this charity, or I managed to get a dishwasher through this. And just by them talking to each other, they were able to figure out. And as I said, there's a cost benefit to it as well. They're saving £1,900 per year. Then we managed to, in terms of patient buy-in, we managed to get a third of our patients to bring in their own blankets to the hospital. And obviously, we all know less laundry needs less energy and less water. We also tried to improve everyone's education about disposing of consumables used during dialysis. So that means the bicarb cartridges. Some nurses weren't sure whether it goes into clinical waste, but then we were able to confirm that knowingly we can get them recycled. We can put them up for recycling as well. And this also made us reflect on our sort of waste streams and see where we can optimize it. One satellite unit didn't have enough space for a recycling bin, and now in chat with the trust, they're trying to see if there's something they can do to try and rectify this. We're also looking at our waste contracts to see if, while we obviously have the most cost-effective one, whether the contracts we have can reduce the carbon footprint or not. Lastly, pharmaceutical initiatives. Our brilliant pharmacist came up when he heard I was doing Green Nephrology. He came to me and said that, you know, we have these patients who are on 2,000 units of EPO twice a week. Why can't they just be on 6,000 units once a week? And there's no sort of, the licensing doesn't mention anything. So we were able to pilot this initiative in 2 dialysis units, managed to get consultant buy-in, and he was able to prove the hemoglobin remained stable despite switching from a twice weekly dose to a once weekly dose. But instead, we ended up saving around 32 syringes per month. And not to mention the consumables, the gloves, the sort of stirret and everything. And when he presented his work at UK Kidney Week, which is a regional conference and here in the UK, he actually ended up winning Best Poster, which means a lot of his peers also found the work to be quite interesting. Then there's also a push for us to start using Podley flushes, because right now we're drawing up a saline using this drawing up needle, a syringe, a saline cartridge. But there's a bit of governance involved in terms of the AT&T technique needs to be changed, but hopefully that should be going ahead soon. So finally, I think my biggest learning through this project was that culture change is key, is a catalyst. Once you have your stakeholder buy-in, once you get everyone on board, once everyone understands why you're doing what you're doing, just the changes become easier to implement. And then within change as well, starting off with low risk, high win, so the cups, the blankets, the online priming, and reducing dialysis flow rates, things that have already been done and proven, was quite simple. And then we hope that even now that I've left Oxford, now I've come back to my training job, the green champions that are embedded in the units, they're sort of continuing the work. And yeah, as I mentioned, the next steps for the unit would be to try and formalize the measurement to see if, especially the heat disinfection project, to see if that money saved is reflected in sort of the electricity meter, in the electricity the units are spending, and develop sort of sustainability KPIs that can be looked at on an annual basis in governance. Then we want to try and make sure that the green champions are meeting every quarterly to share new ideas they've come across, and see if they can take their work further. We're also hoping to use all this work as a foundation to sort of go back to the trust and ask them to give us more capital investment for projects such as redirecting reverse osmosis excess water, having central acid delivery tanks, expand a home hemo program, and then sort of look into green procurement as well. So this is an update I got recently that my green champions are now, this is the project they're working on next, which is reusable tourniquets. So as you all know, in dialysis units, disposable tourniquets are used and they add to sort of plastic waste and procurement costs. And they're now looking into reducing single-use tourniquets by 80% within 3 months. Yeah, so they're going to start piloting in one of the satellite units. And once they've proven that if there's no infection risk, then because they've already taken together so many initiatives, now that pathways and that the steering group exists. So hopefully they'll be able to take this forward as well. That's it for me. Thank you very much for having me. And yeah, any questions?
Ayushi, thank you so much. That's such a fantastic presentation. It's so inspiring to see how much you've managed to achieve. Let me just stop sharing.
Yep. Oh, sorry. Yeah.
Yeah. Perfect. Yeah, it's really inspiring to see how much is done. We sort of say in the kidney module that we've written that, you know, one person can make a difference. And watching your presentation, it's abundantly clear just how much difference a motivated person with, you know, access to these resources can make and how that can scale up. If people we'll move to the sort of discussion part of the webinar. If people are comfortable turning their cameras back on, it does help facilitate a better discussion. And the floor is now open for questions and comments. Liliana, go ahead.
Hello, everybody. I just wanted to say hello. We've met, me and my PhD, Nelisa. We met for RAN at Glasgow Congress, European Renal Association Congress, and he invited us to join you. So it's my pleasure to see you today. My name is Liliana Tuța. I'm professor in nephrology in Constanța, Ovidius University of Constanța, Emergency County Hospital of Constanța on the Black Sea coast, Romania. I listened to Ayushi presentation. Very nice to meet you all. We were very happy that you invited us and honored that you invited us to come and to join your project. We listened to the presentation and we realized that we had a lot of things to do in our hospital. We have a public dialysis center in our hospital, but in Romania, dialysis is mainly private. And I'm sure that in private, they do a lot of more things for green nephrology and green dialysis, but we need to do this in the public hospital a little bit more. So we are going to follow with interest, and as much as we'll study more what you're doing, we'll be very I said again, honored. I try my best to speak appropriate English. So to join you in projects and to come with our ideas for Romania and not only for Southeastern Europe. Thank you so much, and we'll keep in touch.
Thank you so much for that, Lilian, and great to have you and Nelissa both on the call. It was wonderful to meet in Glasgow, and it's a privilege to have you both in the room. And what a fantastic presentation for you both to have heard in terms of the differences that can be made, how much money it saves, how it improves patient lives, the experience of those working in the hospital, as well as the huge reduction of the environmental impact. You might see on the call Harriet, and I'm not sure if Ijan's in the room, but in terms of the New Care associate sites, they'll be the best to sort of follow up and steer and continue those very exciting conversations. So really look forward to working together on that. Helen, over to you.
Yeah, I want to say great presentation and very interested in your once a day heat disinfection. I have to say, historically, working in dialysis for many years, we did use rinse strain, but in my current unit, I think there's been a lot of concerns in previous years about BBV breaches and so on. And I just wondered, was this practice solely related to your satellite units? I take it that perhaps if you had patients of unknown virology or you had acute patients, was that something that you practiced right across the board? I'd just like to get a bit more information. And secondly, I'd also be very keen to link with your technical lead to have a little word with our technical lead about the written evidence around that, because I think there's a lot of fear about transmission of potential BBV, and it's one of those topics that people get very sensitive about. And I think if you work in a unit where you have unfortunately seen the implications of getting it wrong, it's important to have really robust conversations and evidence-based data to back up changes like that. So yeah, be very happy to hear what you've got to say about that, please. Thank you.
Yeah, of course. Thank you for your question. So I'm sorry, I didn't mention it in my slide, but yes, this project was solely for non-isolated machines. So the way Oxford work is if you have BBV or if you're unknown virology, you immediately get put on a machine that's just for you. So it's an isolated machine. These were for non-isolated machines. Now, I, as a renal registrar, I barely, in my ST4 year, I did not understand how dialysis machine worked. But through my entire year, spending time in the workshop with our brilliant tech, Andy, what they've made me realize is that the heat disinfection has nothing to do with sort of the patient side of things. The blood linings and the tubings and everything, they get disposed of. The heat disinfection is mainly to run really hot water across the hydraulics. And our SOP mentioned that if the nurses noticed there was a blood leak or anything, then the machine would still have to undergo a full 45-minute heat disinfection. In terms of written evidence, as I said, what I did was there was Trunk HD, which was the program done in the North. There was one case study published by Peter Jones, who is the renal tech up there. And what I did was I got him to hop on a call with Andy and all our IPC and disinfection practitioners. And what he had a very pragmatic view on it. First of all, these new dialysis machines are incredibly safe. Second, he was like, we check BBV once a month. So in that 1 month, if someone's been naughty, so that you still can't take over the risk completely. So he had this very pragmatic approach that, and he said, I would dialyze on this machine. And the fact that he had so much faith was quite enough for him to convince us. Then we looked at the instruction manuals. So Leeds had done their studies on Fresenius machines, and our unit had Bebron, Dialog IQ, and Dialog Plus, and the AK98s. So if you look at the instruction manuals, they're quite vague about the number of heat disinfections they actually want us to do. They said it depends on the unit's water quality, etc., etc. So we sort of took that as, because again, our renal techs had incredible faith in the water quality, and it got regularly tested for endotoxin activity. So that's why we decided to go ahead with it. And we decided to do it in a very small unit, which was a pilot unit. And as I said, we've been doing it for the last 6 months and we've not had any infection. We did want to do endotoxin monitoring from the actual machines itself, but we weren't able to secure funding for it because I think it would have costed some £6,000 to get it done. So we were just like, let's just crack on. And as I said, we've been doing it for the last 6 months.
Great, thank you for that.
Just a couple of comments from Eleanor Murray, so in chat, so consultant nephrologist out of Glasgow, and I think Green Renal clinical lead for Scotland, I believe. Darbepoetin, we tried to stop weekly and moved to fortnightly or less often and monthly for outpatient CKD ones. Then great effort for getting all these done so quickly and at scale. I find one advocate means one RDU will engage with one project, but it's much harder to spread and to maintain. And that also she would love any safety data and SOPs too for single disinfects, trying to bring an opportunity for change together, but will be a fair amount of resistance. If you want to comment on any of those.
I am. Yeah, so darbepoetin, I think we use, what do we use? We use neurocumrin. But yeah, that was our reasoning, that if our patients in HACC can get away with once a month EPO, why can't our patients on dialysis? So yeah, and the credit doesn't go to me. It's completely Isaac's idea. He came up with it, and he is the one who did the poster during UK Kidney Week. As for advocate, yeah, I think this is where I sometimes, so this project, I submitted it, it was submitted in our Trust Staff Recognition Awards, and it's actually won the project for sustainability. And that sort of, that's incentivized the units so much, and they all got to dress up and go to this awards ceremony. And as I said, they're all like invigorated to keep the work going. And now Oxford Mail have done an article on it, and their pictures are in the mail. So again, they now feel like they're the leaders in green dialysis. And so yeah, I think I was just a facilitator, as in I got everyone talking to each other. Also, it's good to recognize there were 2 nurses that were already quite interested in green nephrology, and as I said, I was just there as a facilitator. I was able to do research, and luckily I had all these wonderful resources that I was able to pile together and sort of come up with a plan. And also to say, you know, these dialysis nurses, they've been working for 20, 30 years, and they can put someone on a machine in their sleep. So they're always looking for something new to do and something innovative. And thankfully, this seems to have caught the fancy.
Marta, over to you. Oh,
you might be on mute.
If you're talking, we can't hear you. Still can't hear you, I'm afraid. Whilst Marta's having a look at that, I've got a question about, I mean, I've got so many, so I'm going to get a chance to crowbar these in, which is fantastic. You were speaking about building culture first and having dedicated sessions for all staff. I'm curious, how was that met when were you able to just introduce a mandatory teaching session for all staff? Was there resistance to that? I'd love to hear more about how you went about building that culture.
I think, as I said, I think it's the very nature of dialysis units. So I got in touch with the unit managers. I said, can I please drop by? I just want to talk to everyone about green nephrology. Is there a time that would be good for you? Pick today. And normally it's a sweet spot when everyone goes on the machine. And then there's a bit of time that the nurses can relax. So only one nurse has to be on the floor, or we can be somewhere central near a nurse's station. And again, it was just resources that I'd drawn upon from the kit care, the sort of the online module that I had put together in a little PowerPoint. And I'd taken my laptop and I just sat surrounded by like 6 or 7 dialysis nurses, and we just had this very informal chat about it. So I think, yeah, so that's literally all I did. It wasn't mandatory. It was just me dropping in. Maybe we'll brag by donuts. So yeah, that's how I sort of went across changing culture. And I think what really helped was their unit managers were quite. We did have a few units that weren't very keen in the beginning, but when they saw the other units, they sort of got quite competitive. They're like, oh, if I heard Mala's doing this about online priming, oh, maybe I should also try it out. We're also doing green nephrology. We're also putting up a notice awareness board on green nephrology now. So it was just sort of pitting them in a nice, fun way, pitting them against each other, sort of making it a bit competitive. And I think that's how I managed to get sort of the buy-in.
Fantastic. So donuts and a sense of healthy competition between units. Love
Yes.
that. Marta, should we try again?
Can you hear me now?
Yes, perfect.
Yes. Now, I was just saying congratulations, Ayushi, because you have done so much during the last year. I remember our first conversations and where you were beginning, so congratulations. And it was just a brief comment about heat disinfections and about all the experience that they have in the north, as you have mentioned. It's been, for what I remember for last year, more than 4 years that they have been doing these single heat disinfections, more than 4 years, if I remember, 4 satellite units without any zero conversions. So that gives us a bit of experience as we are asking for. It's not yet published, as I'm not aware that Stephanie has yet published this data that she has. But what we collected all the information together, and it's in different countries that they are already doing this heat disinfection, like Malaysia, and in Glasgow. I was speaking with people from the States that they have just begun, not even a year ago, to spread their online hemodialysis filtration, and they're using 5008X Fresenius dialysis machines that they allow to legally do single heat disinfections. But those dialysis machines, the 5008X, they haven't arrived yet to Europe. So once they arrive, I don't know when, we will be able to probably do these single heat disinfections without any problem. So let's see. I have to inquire what is going to happen with those dialysis machines.
Thank you, Marta. Yeah, basically for everyone else, I connected with Marta right in the beginning when I'd signed up to be a group champion myself. And they've pointed me in all the right directions as to what were the initiatives we should be doing and where all the resources would be. Single heat disinfection, again, going back to it, I think, yeah, as you mentioned, Marta, this needs to be more data published on it. I think also needs a bit more industry buy-in as well. We need the manufacturer. I tried going to Biberon and being like, this is something we're going to be undertaking. Do you have any sort of pointers for us? And they obviously were not very keen. And but then, as I said, as a unit, we decided to go ahead with it. And it's not a single person decision. We had a governance meeting. We had the IPC buy-in. We had the disinfection practitioners. I think something useful would be, if we do manage to secure funding, would be to do these endotoxin double monitorings and just, again, prove beyond doubt that heat disinfection has nothing to do with, it's literally just your kettle is hot, so you're just descaling it. That's all it is. And if you replace it with a simple 10-minute rinse cycle, it should be achieving the same thing.
It's more of a comment than a question, but I was really inspired by that patient quote that it makes me feel like I'm part of something positive. I think I've so often heard the kind of other side of it, where we might worry what the patients are going to think if we say or talk about sustainability, and that it might be at the expense of patient care. But it seems like there were really, that quote was so inspiring. It must have been such a, must have been great to hear.
Yeah, definitely. And I think patient engagement is something that we are missing in this sort of endeavor to try and reduce the carbon footprint of kidney care. But I said, once they're not, the dialysis patients have so much going on. I did have a few patients being like, nope, I don't want to hear about it. I just want to get on with my treatment. But there was a big majority of patients that were interested in it. And one of the other things, the dialysis units, there's such a community feel to them. They're doing art classes together. They see each other 3 times a week. So just different initiatives that make them feel part of something is something that I find always does really well. So I think that is just speaking to that.
Fantastic. Any more questions or comments on the floor?
I think the dialysis flow rate one was also a very, very easy win, because all I did one day was I walked around the dialysis unit, noted down, and lots of them were dialyzing on 800 mils per minute. Then spoke to the unit lead. She's like, oh, this is how it's always been. This is how the machines have been programmed. Went back to renal techs. They're like, no, we want it to be 500, but the nurses have told us it has to be 800. Then had a meeting with the matron, and the matron was like, no, it's always supposed to be 500. And then I was like, should we just put this matter to rest? And then again, then she issued like this letter to all the units, and then now it's been standardized to 500. Obviously, if someone needs a higher level, then a higher rate, then. And I know there are newer studies. I think one of the seminars, the previous webinars mentioned that even lower dialysis flow rates can achieve the same levels of adequacy and end up saving you a ton of dialysis and water.
I can see lots of people nodding with that final comment. And in fact,
yeah,
I'm so glad
Garrett, I think.
Okay. And I'm so glad my first note I wrote down was small, quick wins. So I'm so glad to hear you say that. And I guess they're so useful in kind of building that momentum to then address the bigger things later on. I guess the question would be, are there other examples of sort of small, quick wins that you started with that you found were sort of successful in reinforcing that culture?
Yeah, so online priming, the dialysis flow rates, just getting all the unit managers in one room, and then them discussing whether bicarb cartridges should go to clinical waste or recycling. So again, they were able to sort it out amongst themselves. So I think that was really important, that it wasn't coming from a doctor telling them what to do, but it was just from their peers. And then other small wins was, as I said, there was one unit that was using mugs and the other unit was using plastic cups. And then I don't think she'd ever thought about it, but then when we brought it up, she was like, oh, okay, I can look. And within a week, she'd managed to get mugs sorted. She had a dishwasher that was coming in. And I guess every dialysis unit is made differently. When it came to the blanket initiative, one unit, unfortunately, because they didn't have enough space, one unit came up with the idea that patients would bring in the blankets, they would store it in a shelf in the unit so they didn't have to bring it back and forth. But then people wanted to bring in electrical blankets, and then it became a bit for faff, because so there are the quick but it's just, you float ideas, you see what sticks, and the main thing was talking about it, and making sure all the units spoke to each other and cross-pollinate. But as I said, I think them winning the staff recognition award at the trust has really invigorated them, and now they're looking into reusable 20Ks. And I think they're thinking with that sustainability hat on. I think units are pushed to make sure that, their procurements and everything are cost effective. They're saving as much money as they can. But now with the sustainability hat on, they're like, oh, okay, if I do this, I can also save money and be green. So I think that's another realization they've come across.
Fantastic.
Yes, I think Francis has said yes, bicarb cartridges. So I think that was a problem. Some nurses weren't emptying the bicarb cartridges in the sluice, but once they were able to talk to each other about it, And they also realized the blood lines also need to be empty. So that will reduce the weight of the garbage, the waste. And again, we were able to talk to all the nurses, increase that awareness. We unfortunately weren't able to measure the outcome of that sort of raising awareness and waste management. I did try and look into it, see if we could pull up waste invoices and things. But yeah, it's something that will take time to reflect in those invoices.
And then just a couple of comments from Marta in the chat. We always work with 400 mils per minute dialysate flow, but trying to assure at least QB of at least 400 mils per minute. And in nocturnal dialysis, 7 to 8 hours with 300 mils per minute dialysate flow. Time for final comments or questions. Anybody from the floor?
Are you going to do the same at Imperial, Ayushi?
Oh my gosh, that is $1 million question. I think so.
You connected with Gloria?
I have connected with Gloria. In fact, I've run into me at a symposium together as well. I think now that we're both back in our clinical role, full-time clinical role. So another thing I think to recognize would be that I was a quality improvement fellow this past 1 year, which meant I was doing a full on-time, on-call rota, but all the rest of the time was I was all dedicated to QI. So I had time to run around dialysis units and drive to satellite units in Milton Keynes, and sort of High Wycombe and talk to everyone. So now that I'm back in clinical, and also I guess it took time for me to build rapport. So this work didn't start until so I started my post in March. We started it in May, where I was mapping our baseline practice, and I think the main changes started happening around September, October. And by then, I think I did other QI projects with the dialysis nurses as well. So I think there was a bit of rapport built, and they started trusting me as well, and we started to get to know each other. So that really helped me build momentum. So hopefully Imperial, let's see. I every time I do go down to dialysis to review a patient, I do try and nudge the nurses and be like, oh, do you think you'd be interested in this? So let's see, if this keeps seeing my face enough, hopefully I'll be able to convince them to adopt some changes.
Do you think so? Are there a lot of QI fellows kicking around? Can we find some more? And because it's quite hard to create sustainability fellows. I mean, it's possible, but there's a lot of work that goes on. But if people are coming into roles, perhaps not realizing the connection to sustainability, that might be more achievable. I don't know.
I think, from my understanding, Oxford has been the only one. The country does a lot of education fellows, but this QI fellow role was quite new, and my post was funded by the Oxford Kidney Unit charity, and I don't think they necessarily thought when I came into the role I was going to do sustainability. And as I said, this was one of my projects. I did something on vascular access as well, and then I did something on social care as well. So yeah, but whether we just need to ask more people to think about sustainability and understand. And you know, a lot of QI projects have sustainability in them already. You're improving a service, you're saving money, you're doing things a different way that might be better. And some of them, if you look at it from a sustainability lens, you could prove that you are making a planet a better place by undertaking this QI project. So I think we probably need to do a bit more, sort of awareness and get everyone to think about sustainability in everyday clinical practice and see, and then put a spin on those things.
Yeah. Just reaching everybody, but it's just, is there a particular, because I think you made that point that just having that time to go and do the engagement and then the auditing and things.
Yeah.
So it's like, who are the people who might have some of that time, who we can find?
I wonder, yeah, who would have the time? That would be a big barrier, I guess. Time is the biggest barrier, and as I said, because I kept engaging with the units, and I wonder whether me keep going in normal clinical life, I don't see myself being able to engage as much as I did during my QI fellowship.
Yeah.
Eleanor, go ahead.
Yeah, just on Francis's point, it's a really good one. The clinical fellows, whatever flavour they come in, can have that time to just dedicate to one thing. So we've actually used leadership fellows before for projects who have been kind of assigned to us, and we've directed them to sustainability things. But absolutely quality improvement, or even teaching fellows, just we nudge them to cover the right topics to the right people, then it can help move things along. I'd almost wonder if the disinfect thing, if, as you say, a lot of it comes down to these are the manufacturer's instructions. There will always be reticence and nervousness about not following those instructions. Should we, as a UK or international community, be trying to open up those channels of communication with the manufacturers and say, can this be reviewed? There is variation across international boundaries. Why? Show us the evidence. If you've not got evidence to say we need to do this, can we please collaborate to work to change the manufacturer's instructions?
Yeah.
It was on our list of to do things, was like find a meeting with different people, but it's hard if we have for us, because we've got a label of Scottish government that are helping fund this work, that it's then hard. It puts a barrier between directly liaising with some of the companies when there's procurement and rules and regulations. But so there's nothing stopping clinicians, renal techs, general patients, community, putting a petition together to say, meet us at the table and let's see if we can hash this out.
Susie's here on the call right now from Fresenius. Susie, I don't know. We've chatted about this, connecting with the right teams in these big companies to take, because I think quite often they are doing some similar work. I don't know if you've got any comment to make.
Yeah, I mean, I think I can just reiterate some of the comments we've had before. I mean, it's quite, certainly talking from a Fresenius medical care point of view, it's very, we have a kind of lot of people globally working on these things. So, I just say, if you've got something that you're concerned about or you want to raise, just reach out to one of us locally, and then we will try and escalate it, and feed it up globally. And I think because the more we challenge, the more we can drive different and change outcomes, because obviously they're looking at things from a global perspective, and quite often I think it's Europe and the UK that are actually moving faster than the global organisation. So, certainly we've known from the work that we've done so far with or the engagement we've had with CSH, that's really kind of been a catalyst for slow but fairly significant changes and increased engagement. So I would say keep pushing, keep asking, keep creating the evidence, because the more that happens and the more we generate demand, the more we can kind of push upwards. But once again, I think the challenge that we have as a sort of a local organisation is some of the stuff that is the great work that's coming out will also impact the CE marking. So we have to be mindful about building that into future R&D. So once again, there may be things that actually seem to maybe not be moving quite as fast as you want, but actually there may be a rationale for that, but it doesn't mean that we can't still generate momentum. I don't know if that answers the question.
Yeah, sorry for putting you on the spot, Susie, but
right.
It just reminded me of those conversations we've had, because I just realising the scale of some of these organisations and the fact that teams could be working on something and other people in the same organisation may or may not know about that.
Yeah, and I think acid concentrate was one of those where actually we found that the market was, the healthcare sector was working on that in its own right, but we were all also working on that as a company, because in the UK we generate most of, I think, the acid concentrate that's sold. So there wasn't that alignment, and so there was a duplication of work where actually we probably could have moved a lot faster had we spoke a lot earlier in the process. So it's avoiding that duplication. So I would encourage people to reach out, because there's no sort of stupid question in sustainability.
And Ayushi, actually, you mentioned the Biberon machines, and I think we've got some good contacts through Kidney Care with Biberon, and perhaps we should take your experience and discuss with them, see if we can get that conversation going in that quarter as well. Yeah, we will connect after the call.
I think, the renal technologists, I would say, are key. If you're a renal technologist, because I'm not a renal technologist, I don't know how the inside of the machine looks. I don't know if you've been to dialysis unit. They all got this massive schematic with lots of circuit diagrams as to how the machine works. And I was like, and he was just like, the water goes to here, this is like, it'll be fine, blah, 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 blah. And I was just like, as long as you're happy and as long as you feel confident, I will put you in the room with the right people. I'll write the SOP, I'll speak to all the nurses, but I need you to be my sort of anchor to help sort of push this forwards. And then obviously we had a consultant as well who backed the idea. So and in fact, he was just like, if this all goes down, it's like my name on the SOP. And I was just like, oh, well. But no, it hasn't gone down, so it's all gone well. But yeah, the other last thing I wanted to float was another thing I noticed was one of our satellite units was a brand new unit. And it just, after learning about all the things that could have been done when they were making this unit, just made me quite upset. It's just like, this unit was made 2 years ago. And if they had thought about their sustainability, had to want to make sure they were redirecting RO water, if they had a central acid delivery tank, if they had maybe sort of thought about more storage or things like that, or like had been not on the second floor where water was being pumped up and then obviously being used, if it was a ground floor dialysis unit, things like that. I wish these were sort of taken into account. But there is still scope for this, because as you know, the entire world's population that are going to need renal replacement therapy is only going to exponentially rise. So I wonder if we could develop something like some rules while constructing a new dialysis unit that might be good practice, that architects and they can refer to make sure these things are installed in the get-go rather than being retrofitted and then not finding enough money for it. And the business case is all there. I think Royal Free have published quite a few on them on the central acid delivery tank and the RO excess. So we already have these case studies. All we need to do is, write up the business case. Yeah, I'll stop talking. Thank you.
No, this is fantastic. It has brought us towards the close of this webinar. There's a lovely comment from Melissa in chat. Green dialysis is not only about protecting the environment, it can also make care more accessible, efficient, patient-centered for people living with kidney disease in Romania. Totally agree. Ayushi, thank you so much for such a wonderful presentation, facilitating such a brilliant discussion. It's always so inspiring hearing a room of brilliant people speaking to each other, and I always leave these with a sense of optimism and hope for what can be done moving forwards.